Professor Sanders. I'm going to be recording a supplementary video on chest tubes and management of patients with chest tubes for our respiratory lectures. One thing I do want to let you know is that this course was originally a 4-hour class, and I have pared it down quite a bit because neither you nor I want to sit here for 4 hours talking about chest tubes. Hopefully I'm going to hit on the key concepts so you have a better understanding as to why we need chest tubes and break down the chest tube drainage system and get a better understanding of how it functions. And then we're going to look at assessing the chest tube drainage system, assessing the patients with chest tubes, and then we're going to look at nursing and go over a few nursing interventions to help promote healing among patients with chest tube drainage systems. Okay, since we're not doing a 4-hour class, I pared it down to 2 objectives. And lo and behold, there are no terms I included in this video. So let's get down to it. All right, so let's talk about the function of the lung, and then let's talk a little bit about the anatomy, physiology of the lung. And that'll help you better understand why we're doing what we're doing. So the function of the lung, as we all know, is simply for gas exchange. We're gonna breathe in, right? Pull that oxygen in, and then as we exhale, we are going to get rid of CO2, which is a result of metabolism in the blood. But what I want to talk about is the disruptions that can happen. What happens when we have disruption of the system and disruption in the mechanism of breathing? When we have a disruption, it basically compromises the lung's ability to function normally, and it decreases our ability to perform gas exchange as intended, and this can severely compromise our patients, especially those patients who are already compromised with some sort of an underlying disease process and those within the critical care department. All right, here we have our patient John. I'm going to call him John because I don't know what else to call him. I'm getting a little tired. It's about my 10th time trying to record this. I keep messing up as usual. Let's talk about our lungs. Okay, so here we got John. He's sitting here. Here's his lungs. Here's his bronchioles. Lungs are nice and open, everything else. So around the lung, we have a protective layer here in blue. This is our visceral pleural, okay? We also have another protective layer that's attached to the thoracic cavity itself, and that is our parietal pleura. And in between these two spaces, we have our pleural space. And this is our area of focus when we talk about chest tubes, okay? It is our primary one, even though we will talk about briefly chest tubes in patients who have undergone coronary artery bypass grafting. Most of what we're going to be talking about is a disruption in that pleural space. And that disruption is what's going to cause a dysfunction in the gas exchange, right? So in our pleural space here, it's pretty big here. It's a very small space. We have pleural fluid, all right? And just to give you an idea how small this space is, on the average adult male, there's only about 8 to 10 milliliters of pleural fluid within that space. And that pleural fluid has very important purpose. So first, one of the purposes is when as we breathe in and out, we can get friction, right? That pleural fluid allows us, the lung and the thoracic cavity, to kind of gently glide over each other, preventing any kind of friction within the chest cavity there, and thereby reducing or eliminating, damage to the lung, basically. But more importantly, what this does is it helps to keep the lung expanded as well. Our lungs are elastic, it's elastic property, and something has to keep them open. So how does that happen? Well, the pleural fluid is a very important mechanism because it creates what we call mechanical coupling, all right? And what mechanical coupling is, this isn't anything you need to know, it's just to help you understand how the lungs stay open. Mechanical coupling, to use an analogy, is like taking a glass of ice water or iced tea or something and sitting that glass down on a glass table or a glass coaster. And what happens is there's some condensation that happens and gets in between those two layers of glass. And if you've ever done it, and I've done this as a kid and even as an adult, you go to pick that glass up and it sticks, right? You can move it around, you can slide it all over, and you get all this wonderful gliding, and you can run it all around that tube, but you pull it straight up, it doesn't come up. And sometimes once I even had to slide it all the way over to the edge to release that suction in there, right, in order to get the glass up. That's coupling. And that coupling is what helps to keep the lungs expanded. One of the mechanisms. The other mechanisms that we talk about is atmospheric pressure. We normally, what we have in the atmosphere is about 760 millimeters of mercury of atmospheric pressure on the outside. And the mechanism of breathing is a change in the atmospheric pressure within the lungs in order to draw air in and push air out. So in the lung, when we breathe, we contract our chest muscle, contract those muscles, expands that lung. What that does is it decreases the atmospheric pressure within the lung, thereby drawing that air in from the atmosphere. All right, and that, like I said, is like 760 millimeters of mercury. But in the that pleural space, the atmospheric pressure in the pleural space is actually about 756 millimeters of mercury. And what that does is that gives us that negative 4 pressure in that pleural space. So when we say a disruption of the negative pleural space, that's what we're talking about, is that negative 4 centimeters of mercury. And this, again, is what helps keep the lung open and expanded. Because when we, otherwise, if we didn't have those two mechanisms in place, when you got and you exhale and you got into that relaxed state, the lungs would completely collapse down to nothing. I mean, just into that small ball. So the lungs don't fully collapse, and that's part of the mechanism and the reason behind that. So what happens when something disrupts that? Something gets into that pleural space, like air or fluid, right? It's going to, like I said, it's going to disrupt the negative pressure in the lung and cause it to collapse. And when this happens, that's when the physician is going to need to come in and evaluate whether or not the patient is going to be a candidate or need to have a chest tube placed. And that is going to be determined by the amount of fluid or air in that space. All right, and how compromised is the patient. And also, they're going to look at whether this is an acute or chronic problem. In the ICU, it's more usually an acute process. So what is a chest tube then? Well, a chest tube, simply put, and I hate to sound like I'm dumbing this up, but it's just a large tube to put into the pleural space to remove air fluid from the and re-expand the lungs. All right. What I included here is I put a picture up here of all these different chest tubes, and I want you to look at this because I want you to see that there are quite a few variety of sites, and by no means is this the only type of chest tubes you're going to see. You've got these larger bores all the way down to these smaller ones, and there's some even smaller than that. We've got them from adult all the way down to preemie or neonatal chest tubes and stuff and sizes. The average chest tube you're going to probably see within the ICU is going to be these two right here. And these are very large bore chest tubes. They're about the diameter of your finger, right? And they're about, I think they're like about 16 inches long. How long is that? About 30 centimeters, I think. 30, 60 centimeters, like 15, 16 inches long. And then up here, what I have is I've got two examples of the type of chest tube placement. On the left, we've got one for a pleural effusion. In the pleural effusion, the fluid, since it's heavier than air, it's going to settle down around the bases, and generally you're going to see a smaller tube, and it's going to go in and be inserted at the base of the lung, where in a pneumothorax, you're going to see, because air rises, you're going to see that chest tube placed high up around that apex. I'm not going to go into actually showing videos or anything about insertion. You can pull that up and look at that at your own leisure on the internet on how to insert a chest tube and discontinue a chest tube if you like. But what we do want you to know is that the chest tube is usually placed in the mid-axillary little bit anterior of the mid-axillary, between the fourth and fifth intercostal space, and that's right around the nipple area. And I know this one's more anterior than posterior, but it's right in this area right here. So it's right up under that armpit area. And what they're going to do is they're going to identify that space, and they're going to kind of go up into an angle and get in between those two. And in order to avoid any of the arteries, veins, or nerves in there. So they want to make sure that they're not causing trauma by putting the chest tube in. This can be done at the bedside by like a lot of pulmonologists will put these in themselves, or at the bedside using our ultrasound to help identify the area, the intercostal spaces, or it can even be done in radiology or by the radiologist using the CT scan. And usually when the radiologist does it, it's going to be a smaller tubing for a pleural effusion versus a pneumothorax. And it may be that patients may need it for longer use, and even going home with that chest tube as well. All right, here's a picture of the actual chest tube. These are the average size that you're going to see within the ICU. Again, you may see some smaller ones, but this is mostly what you're going to see. If you're ever down in the emergency room and you got a patient that comes in, you may, this is what you're going to see, and you may even see something pretty larger. And as you can see, it's a pretty large diameter here, and know that this chest tube is this size all the way up. So it's going to go all the way up and into that high up into the apex there of that lung. And there's the nipple site, which is our landmark to get between that fourth and fifth intercostal space. When you take a closer look at the chest tubes, you're going to see that the chest tube has multiple holes in it. That's going to help facilitate drainage of both fluid and air out of the lung. But one thing I want you to notice is this end piece right here. Look how blunt that is. That is not a nice, comfortable looking tube if you ask me. These are large tubes, and these things are blunt at the end. They're a little bit rounded on that tip, but they're very blunt, and that means pain. That's all I see when I see that, is I think of pain. So when you have a patient with chest tubes, they're going up into that. They're inserted quite a few inches up into that chest. Every time they breathe, cough, or move, these tubes are going to rub and they're going to have discomfort. So always keep that in mind, and that's why I wanted to show you this, is for that end of that. The small ones that we see, they're usually rounded. They're usually more of a rounded and more comfortable, more pliable. These are not that pliable. Okay, am I recording? I am recording. All right, sorry, I took a little break there. All right, let's talk about the reasons to have for chest tubes. So we said we're going to train either air fluid or blood. Air fluid would probably be better to say. So let's start off by talking about a pneumothorax. Definition of a pneumothorax, or whatever, is when air enters into the pleural space, it's going to disrupt that negative air pressure, causing the lung to collapse. Because now what we have is we have a balance between the outside atmospheric pressure and the atmospheric pressure within that pleural space, thereby causing that lung to collapse. Over here on the left, you can see our lung is nice and expanded, and you can see that we have all of this area, all this surface area for oxygenation and gas exchange. In that collapsed lung, when it happens is when it goes down, we no longer have those alveoli open, thereby inhibiting the ability for gas exchange. All right, reasons for this to happen. Well, we can have external trauma, such as in this picture, where there's like some kind of a puncture through the chest wall itself. Or we can have what we call spontaneous. So let's talk a little bit about the differences between spontaneous and traumatic. Because traumatic, we're going to go back to traumatic here in just a minute. So in spontaneous pneumothoraxes can occur or have two basic categories. One is you have a primary spontaneous pneumothorax, and this occurs when the patient has no underlying history, medical history of pulmonary disease or anything that could be causing it. So basically, it's a pneumothorax. We don't know why it happened. Then you have a secondary um, spontaneous pneumothorax, and these are the more common, and they're usually associated with a history of some sort of underlying pulmonary disease. All right. Some of the diseases that can compromise the tissue, the lung tissue, that can create that spontaneous pneumo. And let's be clear, a spontaneous pneumothorax, where a traumatic is coming from the outside, and a spontaneous is going to come from the inside. So some kind of compromise within that lung tissue itself, which is going to allow air that's breathed in to escape and get into that pleural space, okay? That's what we're really talking about here. So diseases such as chronic COPD, asthma, cystic fibrosis, pneumonia, some types of pneumonia, especially if it's a necrotizing type of pneumonia, it's going to compromise that tissue. All right, it's going to cause a break in that lung tissue and allow air to get into the pleural space, thereby allowing the lung to collapse. You can have pulmonary abscesses, tuberculosis, certain kinds of malignancies can also do it. And then connective tissue disorders, which is something I don't think we think about much, such as rheumatoid arthritis. Those people with rheumatoid arthritis are more prone to have a spontaneous pneumothorax. You can also have a pulmonary infarct, such as from a PE or something. And then, of course, you can have aspiration of a foreign body. And the reason I think we put that one under spontaneous is because it's more from an internal source versus an external source. Can't imagine that. I've never seen that happen in an adult. You can see that maybe in a pediatric more so. So when we talk about trauma and traumatic, when we talk about the pneumos, we have underlying ARDS, pneumonia, emphysema, and stuff like that. And then we have traumatic, like I said, the traumatic. And when you think about the traumatic, also want you to think about line placements. When central lines are put in, they're generally put in up here. We used to put it in right in the subclavian, right around this area here. And when they would go in, they could clip that lung, the apex of that lung, causing a pneumo. Nowadays, we have a tendency to put them into the IJ, where we have a straight shot in, and you're less likely to cause a lung to collapse. But procedures can also cause the lung to collapse, just so you know. So central line placement, Swan-Ganz, surgical procedures up around the face and the neck area can cause that. And then other things such as bronchoscopies can also cause that to happen. And some abdominal procedures can actually compromise the diaphragm, causing a pneumothorax as well. When we talk about the critical care setting, I was looking at some studies, and the majority of the studies found that a good portion of these patients, about 55% of the patients in ICU, have pneumothoraxes that are due to invasive procedures, and that the rest of them come from some sort of a barotrauma. So a patient with an underlying cardiac history, or not cardiac, pulmonary history, or a patient who has ARDS, really severe ARDS, who's on a ventilator with that positive pressure, it can cause a compromise in that lung tissue and cause air to escape into the pleural space, disrupt that negative pressure, causing the lung to collapse. So here's some chest x-rays. I loved this one because this one actually showed me a little bit more definition. But here on the left is what you're going to typically see on a pneumo, and this is a large pneumo, okay? And what you're going to see is, if you can look closely, try to close your eyes, don't look at this one. By looking here, you're going to see this margin. See that nice margin that goes up and around? That's the lung. This is the whole lung, right? You can see it right there. All that black space, look at, there's nothing. It's all clear. That's your pneumothorax. On this side, you can see the lung is fully expanding. We know it's expanded because we can see all that little vasculature and all that little bit of fluff going on throughout the lung fields. Here's your chest tube that's placed. You can see with the pneuma, they want to place it high up. This one fairly high up, but probably better if it was up here, but I'm not a doctor. And then you can see the holes here and here. You can see the holes. It's going to help remove that air out. And then this one in the right is just going to give you, shows you a little bit more definitive where that chest tube is and the lung margins, and then all of this is being air. It's really kind of fascinating. It's really fascinating to look at chest tube placements before and after. When you look at a pneumo, put a chest tube in, and then look at the post chest tube placement. Know that when you do a chest tube and there's chest tube insertion, you must get a chest x-ray after the procedure is done. That is the only way to confirm that placement of that chest tube, just like any other invasive line. All right. And then it's going to help us identify, well, one placement, and then you're going to see a difference in the expansion of that lung as well. You should see an immediate expansion in that lung. All right, the next category of compromised pleural space there is going to be our fluid, all right, and pleural effusions. Now, when we say pleural effusions, I think we automatically think of some kind of, I don't know, yellow serous thing, but know that pleural effusion, all it means is fluid. That's all it means, is fluid in the pleural space, all right? And there are many different types. When we have fluid that comes into the lung, it's going to go to the bottom, settle at the bottom versus the top like air does. And as you can see, now what has it done? It has actually changed that pressure in there. It's probably creating a higher pressure, pushing on that lung up, right? So now you don't have that -2. You got a higher pressure in that, thereby not allowing the lung to fully expand and giving us decreased surface area for gas exchange. Okay, like I said, pleural effusion is just a general overview, right? General big thing, kind of like COPD, which encompasses that big umbrella. But when we talk about a pleural effusion, our pleural effusions are generally classified by the type of fluid which is found in that pleural space. For example, a hemothorax, that's fluid in the blood, blood, right? Empyema, infection. Chylothorax, this is caused from lymphatic drainage. And then another reason for chest tube and fluid in there would be from thoracotomies and CABGs. I want to talk just briefly about the CABG real quick. When we look at the chest tube placement, we are not only going to see it pleural chest tube in usually in the left pleural space, but what you're going to see is you're going to see chest tubes underneath that sternum into the mediastinal plate, into the mediastinal space. And what that's going to do is, because when you do open heart surgery, you got to cut through that pericardium, and it can seep some fluids, and we want to make sure that we drain that, because it can cause increased endothoracic pressure there, and fluid can build up, and it can cause a tamponade, right? And then thoracotomy. But know that the different types of fluid is going to indicate they're all still considered pleural effusion. Okay, so what are some of the causes what are some of the things that can cause that pleural effusion? Well, trauma to the chest, it causes bleeding. Diseases such as tuberculosis can cause an accumulation of fluid. Lung cancer can cause that. Patients with lung cancer, it's not uncommon for them to have a long-term Pleurex put in, which is that first picture that we saw up there with that that single bottle drainage system. You know, patients with emphysema can also have an accumulation of fluid in there. And then, of course, we have things such as bleeding disorders. Bleeding disorders where the blood's not clotting properly and everything else can cause it can cause a hemothorax. It's not traumatic. So there's many reasons that we can have it, but know that again, pleural effusion is just accumulation of fluid, and it is distinguished. The type of pleural effusion is based on the type of fluid found in that pleural space. All right, so here's a chest x-ray of a pleural effusion. And this is actually, I love this one because this actually is the same patient. So here on the left, we got this woman here with a pleural effusion. And look at this. All of this is fluid accumulation down around the bases of her lung, both lungs. After they went in, you can see now they've put these small tubes in here. They're down at the base, okay? And that's going to drain that fluid out. And you can see the before and after is just really remarkable. I can imagine how much fluid they took off, because you can hold at least a liter in that bottom of these bases. Easy. So they took a couple of liters off of this patient. And now you can see the lungs are now fully expanded here. And you got nice, the nice diaphragmatic angles going on right here. But all this area is now open for gas exchange, where before we had limited, very low volumes for gas exchange. All right, those were the two primary reasons for chest tube placement. But you can see they still go in the same place, that pleural space. Contraindications. Well, chest tube placements are generally life-saving procedures for patients, so there's no true contraindication. There are what we call relative contraindications and things that need to be taken into consideration when placing chest tubes or evaluating a patient for chest tubes placement. Patients who have pulmonary adhesions from previous surgeries, you want to be cautious on those. They can cause trauma and cause more damage than what the benefits would be. Coagulopathy, any patients with bleeding disorders. And this is why it's important to make sure you're monitoring your patient's labs, especially prior to procedures. We want to make sure we're looking at those platelets. We want those platelets, if they're under 50, they're going to be, depending on who's putting it in, they may or may not put the chest tube in. And then again, they have to weigh the option, the benefit versus the risk. But if you have a coagulopathy problem, you got low platelets or something, or you have an INR is too elevated, you can expect the physician to order something like FFP or platelets prior to the insertion, or be infusing them in as they place the chest tube in, and this will decrease the risk of bleeding from the chest tube placement. And then also we want to look at another thing that the doctors need to consider is anybody who's had anybody with hernias, abdominal hernias, those great big huge hiatal hernias, right, pushing up on there. That tissue is already compromised. They go in and put that in. They can clip that and they can puncture the diaphragm. The only absolute contraindication on a chest tube placement is inserting a chest tube against the patient's wishes. That is never recommended. That's the only true contraindication. The rest of them are things that need to be seriously considered. And then again, they need to weigh the benefit versus the risk of the placement of the chest tube. So what are some of the risks associated with chest tube, placing a chest tube? Well, bleeding. We just talked about bleeding. Not only from coagulopathy, but then again, you can clip one of those veins or those arteries during the insertion, causing bleeding into that chest, bleeding from that, and that's a complication. You can have a local site infections at the insertion site, and you can also have a deep organ space infection, okay? And that's where that infection is going to get down into that pleural space and cause some empyema on top of like a pneumo or something. And I think this would probably be potentially related to either poor insertion technique or patient management. And we'll talk more about that. You can get subcutaneous emphysema. And we talked a little bit about that in class, where you get all that crackling and the crepitus. You can have lung trauma where you have a perforation of the diaphragm. You can actually get in there and cause damage to either the spleen and or the liver. You can have bronchial pleural fistulas that develop from that. And most commonly, you can have a malpositioning of the chest tube, not tub, chest tube itself. I want to go back to the re-expansion pulmonary edema. This is something that does not happen very often. It only happens in, like maybe 1 or 2% of the patients with that. When you put a chest tube in, immediately after you do it, especially if you have like a pleural effusion and you drain the fluid out, they get that little coffee going on, right? And it may last for an hour or so. That's from the re-expansion. But you need to be cautious of that because when we re-expand the lung too quickly, either from a pneumothorax or from a pleural effusion, we can actually cause pulmonary edema to occur. Now, the exact mechanism of this is unknown, but what they think it is due to is that rapid reinflation, where if they were talking about pleural fluid, maybe greater than 1 liter or 1.5 liters, and what they think is it's due to the rapid permeability, increased permeability due to the hypoxic injury to the lung tissue. So it rapidly inflates and boom, everything kind of goes in and it comes out. Now you got pulmonary edema. So this is something that you need to really make sure you're monitoring and looking at on your patient with chest tubes and stuff. But know that it is common to have a little bit of a cough after. Now, if you put an central line in and you start getting a little cough like that, you need to get a stat chest x-ray because that means they probably have a pneumothorax. Okay, these two chest x-rays here are prime examples of misplaced chest tubes. When we talk about the one on the left here, when we look at this one here, one thing is that look how it's not very far in. That pneumothorax is sitting high up and in here. That chest tube's here. Now this could either have been from the insertion in itself, or this could be when the patient moves and it's partially pulled out. But what we're looking at here is you see here's your hole here, that break right there in the line, that's a hole for the drainage. But look where the other one is. It's sitting way out here, all right? When it sits out here, what's going to happen is we're going to get an air leak going on, and we're going to end up with subcutaneous emphysema happening on this patient. We're at high risk for that. So this is a misplaced, I put this in with misplaced chest tubes, and we're going to contribute this one to the doctor, not the nurse. We're going to say he just didn't put it in high enough. This one here on the right, look at this, it goes up and over. And I think we looked at one similar to this in class, but this happens in patients with COPD, emphysema and stuff like that. You can actually get it where it perforates and goes right across the mediastinum and right up into the other side of the lung. So these are two examples of chest tube misplacement. And again, the only way to confirm the chest tube placement is by getting an immediate chest x-ray following chest tube placement to verify positioning of that, just like you would with any other kind of invasive line. All right, last thing I want to talk about before we actually get into the chest tube drainage system itself is a tension pneumothorax, all right? And what a tension pneumothorax is when air enters into the pleural space but cannot fully escape. So basically air is going in, and in. And whatever is happening, it's a one-way valve. So air goes in, no air comes out. And this, as we know, is a life-threatening emergency. Okay. So basically, like I said, it's acting as a one-way valve. So during inspiration, a sizable high pressure collects and accumulates in that inner pleural space, and it's unable to escape. And what it causes that lung to collapse down, and it causes everything within everything in the chest to shift away from it. So you can see here, you got that pneumo that's going in here. And if you look, here's your ET tube. Here's your spine right here. Okay. Here's your trachea way over here. Here's your bronchioles way over here. Everything has shifted over. All right. And this, like I said, is a life-threatening emergency. Okay. In severe cases, this can increase, excuse me, it's going to increase that intrathoracic pressure. It's going to cause decreased venous return to the heart, decreased cardiac output, and it's going to actually put enough pressure on that heart where it can cause a tamponade on cardiac tamponade, right, and lead to cardiac arrest. Okay, yeah. Sorry, I just had to make some notes and I had to pause it here. So hypoxia, it also triggers vasoconstriction, increases pulmonary vascular resistance. And as a result, you got hypoxemia, acidosis, decreased cardiac output. And like I said, it will ultimately lead to cardiac arrest if not immediately relieved. This can be relieved by either a needle aspiration or a chest tube placement. And anybody who's been over at clinicals recently over at St. Mary's, we actually had one a few weeks ago. And I know I was showing a bunch of people that tension pneumo, and how that man was sitting up and looking around was just beyond me. But know that this is very severe and doesn't happen very often, but it's immediately life-threatening. All right, enough about the lungs and all of that. Let's get into the actual chest tube drainage system now. So what we're going to look at is we're going to look at the 3-chamber system. We're going to break that down into the individual chambers and see how they all kind of relate to each other. It's really kind of cool. All right, so there's our 3 bottle. We saw that in class. We're going to have a collection chamber, a water seal chamber, and one that regulates the suction and regulates the amount of suction. I've got a note over here. It says eliminate this slide. Huh. All right, let's start with the single bottle system. All right, so a single bottle or a single bottle system can be used. And it can be used for a couple of different reasons. If we are draining a pleural effusion, pleural effusion, the doctor's going to go in and put a small tube in. Usually what we call a Wayne's catheter in. It's a very small tube. He's going to go in there and he's going to get it placed. And he'll actually hook it to a single one. And it's a little different than this setup. And it's going to have a negative pressure in there. We put it in, we open it up, open the clamp up, and it pulls. That suction will help pull all that fluid out. This particular one is just looking more at a pneumothorax. So let's say this is on a pneumothorax patient. And what this single bottle is going to do is it's going to prevent air from getting back into the pleural space. All right. So it's going to allow air to drain out of the lung, and it's going to prevent air from returning. And how this happens is through the water seal. So we have, I'm going to change this over here. So we have the bottle. We got our patient, we got our chest tube, and it's going to come down into a single bottle. It's going to have an airtight seal thing going on here, and then we're going to have an air vent here. All right. The tubing coming in is going to be submerged in 2 centimeters of water. This is, I don't know why they got this saying 200, but that tube is only going to go into 2 centimeters of water. And what this is going to do is going to allow the patient, as they breathe, to the increased pressure in the chest, is going to be able to overcome that 2 centimeters of water and bubble up and out and exit through the air vent. Okay. This is a passive process, and the reason I say it's a passive process is because it is not using anything to assist the air to escape out of the patient's lung other than the patient's own respiratory drive, okay? In patients that have something like this, we don't generally, well, we do have this. When we have patients that we hook to a water seal, we want to make sure that they're expanding those lungs. So we want to make sure they're using like an incentive spirometry, because if they're not deep breathing enough and expanding the lungs enough, they're not going to produce enough interpleural pressure to overcome this hydrostatic pressure of this water and the water seal. All right, let's make some color. So I know that's two centimeters right there. So air comes in, overcomes that, bubbles out. But what happens if you have some drainage? Well, if you have drainage that decides it wants to start coming out of here, we now have a problem. We have that 2 centimeters of that water seal, right? That water seal prevents air from going back into the patient and allows it to escape. But what happens if blood or fluid of some kind changes this? Do it that way? No. What if it goes higher up? There we go. So what if that fills with blood now? Well, if it fills with blood, what's happened is now we have changed the hydrostatic pressure in which the lung has to overcome in order to get the air out, right? So you're not going to have re-expansion, and the air will remain in the lung here, and it does us absolutely no good. So in order to get around that, what we are going to need to do is we now need to add a second bottle, okay? So now what we're going to do is we have the second bottle, and now you can see we got bottle 1 here, bottle 2 here. So we're going to now have our chest tube coming from the patient going into our bottle 1, and you can see it's not submerged. This is going to be purely for collection. We're going to have a seal here, and then we're going to have a tube coming from that bottle connecting over into our second bottle, and this goes to our 2 centimeters of water. 2 centimeters. Looks like, I don't know, 2 centimeters right there. Okay? And what this is going to allow to happen is it's now going to allow for any fluid in the chest to drain into the collection chamber, but yet it's going to allow the air to pass through. It's going to allow the air to pass through there, into here, through that 2 centimeters, that one-way seal that we got there, and escape and vent out into the atmosphere. That's the second chamber, or the second bottle. All right, this is also a passive process because we don't have any suction or anything else. So this is what we call a 2-water system. Now, when we talk about patients and chest tubes and they're on a water seal, even though they're on our modern chest tubes, this is the process that's actually being used. So we don't have any suction. So again, the patient breathes in, they breathe out, and that air moves out. And again, what this does is it prevents the hydrostatic pressure from changing in this bottle here by that fluid accumulating here and increasing in here. Sorry guys, I had a brain fart on this slide. We're going to move on. So what happens if we have a patient that has a large pleural effusion or a large pneumothorax, and they need more assistance? Well, one thing that we can do, we need to hook them up to suction. But if you hook them up to suction in this one, so if you hook them up to suction here, you're going to have a problem, okay? Well, it can help pull air and blood and fluid or whatever out of that pleural space. You can also produce it produces trauma. I can't believe I'm messing this up. Sorry. Right? There's risk. So there's no control over it. So you can hook this to suction here, and it'll start bubbling here, and it'll start sucking everything out. But there's nothing regulating that, right? And what this can do is it can cause trauma within the chest, trauma such as hematomas or tissue damage around those holes that we saw in those chest tubes and everything. So in order to eliminate that, We're now going to add the third bottle. And adding this third bottle is going to allow us to apply suction to give better drainage, either for the air or the fluid in that interpleural space, right? And reduce those risks of injury to the patient, okay? So how this is done is going to be based off of the third tube. That's this one right here, or the third bottle. So we have the collection, we go into here. So now we're going to add a third bottle. So now we're going to take that air vent, we're going to connect it back over to this other bottle. And as you can see, it goes into here. And then this escaping one here goes out to the suction unit, and that's where we're going to turn our suction on. But this tube right here is the important one right here, this center tube. This chamber is going to have more water in it, and the depth of the tube that goes from the atmosphere into that water is what regulates the suction, that negatives 10, 20, 30, or 40 centimeters of suction. And we're going to put fluid in there as high. So if the doctor wants 10, we'll put 10. We'll say that's 20, and then we'll say negative 30, right? So that would be that negative 30 centimeters suction right here. So the depth of this tube is what regulates it. So now when we turn it onto the wall suction, no matter how much we put on that, apply suction from that wall unit, anything over that volume, that depth of that tube, that negative 20, 30, or 40 centimeters is going to be pulled from the atmosphere into the suction rather than being pulled from the patient. And that's how we regulate and actually regulate that. All right, guys, I'm going to move on. Sorry that explanation was not as good as I liked. However, we're like 45 minutes into this, and I do not want to start this over. So let's just keep moving on. Anyway, that's the basic principle, okay? That water seal in here, the depth of this here is regulates the amount of suction, negative 20, 30, or 40 centimeters. Anything over that, when you're applying too much excessive suction, is not going to traumatize the patient, will be pulled from the atmosphere and out into there. So it eliminates that risk. And this is now what we have. Those three bottles are now all contained in these units. So now we can actually look at modern day chest tubes and have a better understanding of what's going on here. At least I hope. All right. Going back to that other slide real quick, that is what we call a wet seal. So this is going to look at two different chest tube drains here. One is going to be a wet seal and one is a dry seal. And we're going to look at the differences between them, but they're exactly the same with only one difference. So in our wet seal, all right, we have our chamber one, collection chamber. This tube comes from the patient, all right, it goes down into here. When it gets up, it overflows to the next one and then overflows into the next one, all right? So fluid will accumulate in here. Air will pass through into this second chamber here. This is bottle number 2 now, okay? Right there is that fill line, and that is your 2 centimeters of water, creating that water seal, okay? So when the patient breathes in and air comes through, you're going to see a few little bubbles that come up throughout here. That's normal when you first put chest tubes in. They have a little bit of water or a little bit of air leaking through there. And we're going to talk about that in a minute. This third chamber on a wet seal represents that third bottle with the tube submerged in it. And you can see right here, there's a fill line. It's hard to see on this one, but there's a fill line right here. And then you're going to have different markings on here and you're going to put water in here and fill it to 10, 20, 30, or 40 centimeters according to what the doctor's orders are. And then this tube right here will hook to your wall suction. And then up in the top, right back behind this plate here, is actually your air vent, okay? And that's your water seal, the same as a 3-bottle water system. 1, 2, 3. This here on a dry suction is more of what we're going to be seeing. We no longer have to put all that water in. Let me back up one thing. When your suction is on, you will know your suction is on because you're going to see bubbling in here, okay? We don't want such high bubbling it's spurting out and up and into this tubing here. We just want a nice gentle bubbling in here, and that's how we know our suction is on. When we don't want we want it to water seal, we just basically you're just going to unplug it and clamp it from here, or from here you're just going to unplug your wall suction or turn your wall suction off, and that puts it to water seal. So we're no longer applying the suction, but you'll know your suction is on when you see bubbling in this chamber. On the dry seal, same thing. This is actually a patient with a pleural effusion, right? Pleural effusion. You can see we got drainage coming into here, chambers here. We got our water seal right here, okay? But this one is dry because it does not use the water in it. It's going to use a dial in order to indicate the amount of suction we're going to apply. And there's a lever on the side here, and all you have to do is turn it, and it's normally comes at preset at 20 centimeters. But as you can see, you can do 10, 20, 30, or 40, and all you have to do is turn the dial on that, and it's going to take the place of that water seal on the wet one, on the wet section. Okay, so we don't have to no longer put all this water in and worry about keeping that level where it needs to be. We're going to use this dry seal here. Like this, like the wet seal up and in here, there's going to be a valve to open to atmosphere. Drainage comes in through this tubing here. We hook it to suction through here. But how do you know this is on? Well, we said in the wet section, we know it's on when we have bubbling. But how we're going to know it's on is by this little billow right here. When your suction is on and it is working, that billow will expand out into that window. So if you come in and you see you check your patient and that thing is not there, your suction's not on. You need to figure out what's going on. Is it turned off or what's happening? And then you can see it's fully expanded when it hits that arrow. Okay. Now this can vary a little bit depending on the setting of the suction. So if you're at a -10, we expect it to be a little bit to the left of the arrow. At 20, we expect it to be like right on that arrow. And if it's at like the 30, and especially at the 40, we expect it to be at the right side of that arrow right there. But that's really the only difference in it. So that we have between the two. This uses a dial and this uses actual water. All right, let's talk about assessments now. I know this is video, it's only about an hour long now, but let's get into our assessments, a patient assessment and assessing the chest tube sites and managing these patients. So when we go in and assess, obviously we want to do our initial assessment. And what does that mean? It means that we're going to look at the patient. We're going to look at their overall appearance of the patient. Does their color look good? Are they showing any signs of cyanosis, right? We want to look at their vital signs, and start evaluating those vital signs. Are they tachycardia? Is the blood pressure stable? Is it high? Is it low? Are they running any fevers? We want to make sure that we're looking at that oxygen, their O2 sats, oxygenation levels. And we want to see if they're on oxygen. And if they are, we want to make sure we're noting how much oxygen. These are all basic assessments that we do on all of our patients. This is just part of our head to toe assessment. Auscultation. We want to make sure we're listening to the lung sounds. Very important that we listen to those lung sounds, especially those with chest tubes. It can indicate whether or not we're getting better, staying the same, or getting worse. All right. Do we have breath sounds around that chest tube side or on the affected side? Did we have good lung sounds yesterday and today we don't have any lung sounds? Okay. I know this says to check your breath sounds every shift, but you want to do it every shift, and you want to actually, in a critical care setting, you're going to probably be doing this every 2 to 4 hours. Realistically, we should be listening to the lungs every couple of hours. We want to make sure that we're going in and we are assessing the chest tube dressing and insertion site. Okay, so check the dressing and the insertion site. All right, is the dressing drying, clean, dry, and intact? We're going to look for any signs and symptoms of redness, signs of infection, any drainage coming from around the insertion site. And then we're going to palpate around the surrounding area, and not just directly around that, but a wide range around and chest tube site and up into the chest and even up into the neck. And what we're going to look for is any kind of crepitus or that subcutaneous emphysema, which could indicate that there's an air leak going on in there. Gosh darn it. I hate my notes. All right. And then when we look at and we talk about observing and checking for the quality, we want to check for the quality of the patient's respirations. Obviously, we want to do that. Are they using ancillary muscles? Are they breathing hard? How fast are they breathing? All of those things are a part of that assessment. So we're doing that general patient assessment. We're also going to be assessing them and their level of pain. Remember, like I said, those tubes are big, they're uncomfortable. We want to make sure that we are assessing their level of pain and we are medicating them appropriately, right? Because we want them to re-expand their lungs. Patients with chest tubes have a tendency to breathe a little shallow. They're not deep breathing. They're not coughing, and they can develop atelectasis and other complications. And then, of course, we want to make sure that we are checking and reviewing their labs and checking physicians' orders. All right. Do they have chest x-rays ordered daily? All right. What are their orders for the dressing changes? Are they daily? Are they PRN? What are they? And then again, we're going to review those labs and we're going to look for any signs and symptoms of infection, right? What's our white count doing? You know, what are our platelets doing? What are our bands doing? I mean, we're looking for any and all that stuff. So that is your initial overall when you walk into the room, right? Part of our assessment on our patient is going to include assessing the chest tube drainage system in itself, okay? You can do it from the patient out to the wall section. You can go from the wall section down to the patient. It doesn't matter, but you need to check that entire system, all right? And it's important to remember that you need to do this upon your initial assessment. And every time you enter into that patient's room, you want to be looking at that chest tube drainage system and looking for any potential problems, all right? We're going to start, I usually start up around that wall section. Is my suction on? Is it to continuous? Did the doctor order it for continuous suction or did he order it for water seal? If he ordered it for water seal, there should be no suction. Your suction should never be hooked to intermittent suction. And let me stress that to no end. You do not use intermittent suction on chest tubes. You're either going to have continuous suction or you're going to have your suction off and you're going to have it to water seal. When we look at that wall section, how high up is that wall section? You know, we don't want to go have it too low. A good rule of thumb is usually you're right around 80 to 100. Okay, you're going to look at that drainage, the bubbling, all right, or that little billow in the dry section. Is it there? If your billow's not open and everything, then we need to check and figure out what's going on. Why is the suction not working? Is it the wall unit not working in itself and it needs to be changed out? And if that's the case, please don't wait several hours to get it done. Get that done immediately, especially if they're on a high amount of oxygen and requiring all of that. We don't want to have them sit in a water seal when we need suction, so change it out. If it's a water seal, do we have a nice gentle bubble? Okay. We also want to make sure that we are checking the control dial on that actual, so moving down, let's just move down. So now we've done that, we're going to go to make sure that the suction is actually plugged in. If it's not plugged in, it ain't going to suction. Sometimes those connectors come out and you don't have suction. Plug it back in. Make sure at the suction canister. Make sure working your way down at the chest tube canister itself. Is it plugged in properly to the top of that suction or the collection can, the chest tube drainage system? If it's not, you got no suction. You got water seal. Okay, those things need to be looked at. We need to make sure that we have stabilization and that the chest tube is stable. And what that means is that it's not going to be tipping over. So we need to make sure that that's in a secure area, that nobody's going to be coming in, tripping over it, kicking it or anything like that. A lot of times you'll see that we'll take pieces of tape. There's a device on the bottom that will move, that will snap into place. And typically we will tape that down. Sometimes you can actually hook that onto the lower edging of, there's like a bar on the bottom of the bed that's over there, little hook. You can sometimes hook it onto that. Okay, so we want to make sure that it's stabilized. And then of course we want to check all the connectors. So every single one of those connectors that are at risk of having an air leak in those connectors. So are they tightly in place, right? Some places and some facilities may require you to put tape around those connectors, some do not. All right, but we need to make sure that those connectors are in place, because if they come dislodged, air can get in there, create an air leak, and we can have more problems. And then we want to make sure we're checking for the patency of the tube itself, working your way from the chest tube up to the patient. Is it patent? Do we have drainage coming out if we have fluid that we're draining? If it's air, we need to make sure, right? Well, air, we really shouldn't have anything. We might have a little bit of scant in there, but you shouldn't have too much. But if you're draining fluid, you want to make sure that the tube is patent. And it's not enough to look at the tubing that's coming off the side of the bed down into the chest tube. You got to follow that all the way up to that insertion site, because that insertion site up there, you can get clots that are up there that hit high up, right around the insertion site, right up underneath that dressing. So it's important to make sure you're looking for that, especially if you got a patient that you're draining fluid out of, because it will obviously stop the drainage and stop the flow. Thereby you'll have more accumulation and a re-expansion of that pleural effusion. And then we want to make sure there's no dependent loops or anything going on in that chest tube. Dependent loops, just like your Foley catheter, you do not want dependent loops in there. It can interfere with the movement of the fluid or any type of, blood clots. It can cause that. And then we want to check to make sure that the tubing's not kinked. And this is really important, especially when you're looking at repositioning your patients, okay? That's going to clamp that chest tube off again, all right? And again, clamping it off, fluid, air continues. There's an expansion of the pneumo, expansion of the pleural effusion, and it's going to cause more problems. All right, on our chest tube, again, check for bubbling. The bubbling that we're checking for, there's going to be two areas, and I'm going to show you a slide in the next here that's going to talk a little bit more about the bubbling. And then we'll talk about the titling as well. We want to check the drainage and the type of drainage coming out of that chest tube. We want to make sure that we're looking at the color, consistency, and the amount, okay? If you've got bleeding that's going on in there, we need to make sure that it's controlled. Another thing is that if you had that patient yesterday and there was no bleeding or drainage out of there yesterday, and then today you've got drainage, you may have a problem in something, and then you're going to need to notify the physician, okay? If you had clear drainage yesterday and now we got cloudy drainage today, we have a potential for infection. You need to notify the physician, get orders for cultures and everything else, draw cultures, and get that sent off to check for any kinds of infection. If you've got blood draining out of there, especially if you've got a large amount of blood, post-operatively, right out of surgery, anything 200 or more. Honestly, if I was out on a telemetry or med surg unit, if I was getting 100 out an hour, I'd be concerned. I'd be calling the doctor. We need to get blood work ordered, look at their bleeding times and everything, and see what could potentially be going on there, and then get another chest x-ray and so forth. Also, another thing that we want to do is we want to ensure that we have safety. We have chest tube clamps at the bedside, and this is a safety precaution, okay? We need to make sure that they are there. We usually have these small plastic ones. You can have them there, hang them over your IV pole, but they need to be in the room for emergency situations. And then we want to check for range of motion. We want to make sure that the patient can still move around, right? They're going to have a tendency not to want to move their arms or anything like that. And we want to make sure that, you know, that we encourage range of motion on those patients. All right, I guess that range of motion needs to be on the actual patient assessment rather than the chest tube drainage system assessment. But regardless, we're going to check range of motion. Another thing that you need to check for is how much, when we're checking the chest tube, the drainage in that chest tube, we want to make sure that that chest tube drainage system is not getting overfilled. If it's getting close to hitting that 2 liters where it's filled, we need to consider changing that out, okay? So those are just some of the things we're going to look for. So again, start at the wall section and work your way up to the patient, or start at the patient and work your way to the wall section. But we want to make sure we're doing that thorough assessment on them. And we want to make sure that we're looking at that chest tube each and every time we enter into that room. Again, for stability of the drainage system and whether it's on, and then how much drainage is coming out. Because those things can change very quickly. All right, let's go back to the water seal here, and then we're going to talk a little bit about air leaks. This chamber, this is your 2 sonometers. That's your chamber 2, creates that one-way valve, right? And everything else. But I want you to pay attention to these numbers. You got 5, 1, 2, 5 going on in here. What you're going to see is when you have a patient that comes back from or has a chest tube placement, chest tube that it's put in place, or just comes out of surgery that had a chest tube placed in surgery, it is going to be normal to see some air bubble up and out. Okay, it's going to come down and it's going to bubble up and out, and you'll see it looking like that. All right. As the lung re-expands, we expect that to diminish. If you're assessing your patient and you see that in the morning when you looked at it, there was no bubbling, and now you see bubbling, you need to investigate for an air leak. There's a possible air leak. And what we need to do is you've got to start looking at from the connection all the way down to that suction again and trying to troubleshoot it. And a lot of times what we do is we start, how we evaluate is we will take a pair of those clamps and we will clamp it up near the insertion site. With the suctions on, we're going to take the clamp and we're going to clamp it, right? If the air leak stops, then you know that that leak is coming from around the insertion site itself. If you still have an air leak, we're going to move down to the connector now. Okay, and I'm clamp right below that connector. Clamp it off. If the air leak stops, you know that that connector is where the air leak is occurring, and you're going to have to try to resecure that or figure out if there's any way to reduce that down. You never want to leave that chest tube clamp on for more than 1 minute or so, because again, you're creating higher pressure and defeating the purpose of having that chest tube in as well. So if you had a pneumo, you can have that pneumo re-expand in that short period of time. Within a few minutes, it can re-expand if you have that, leave a chest tube clamp on. And then one other thing is that you never want to clamp those tubes off when you're transporting your patient. When you transport a patient, you want to make sure that the chest tube drainage system stays below the level of the chest. And you want to make sure that it is, all you have to do is disconnect from the suction. That leaves it to water seal, and that's a safer option than trying to clamp it. But clamping is not a good option. Okay, back to the this chamber here. If you want to know the severity of your leak, you're going to look at these chambers here, 1 through 5. Okay, so say you come in this morning and you have the chest tube put in, and they just put it in a couple hours ago, and you got this little bubbling going on here. Well, we can say, yeah, that's kind of normal because the lungs are expanding and stuff. But if you see bubbling that is way over here, the higher it goes up, the more severe the air leak. Okay. And that's one of the importance of looking at this chamber as well, because most people don't understand or know what the meaning behind these chambers are. It can go through 1 through 5, and in some cases you'll see it as high as 1 through 7. But that's how you're going to gauge the severity of an air leak. You can see here there's no air leak because there's no bubbles. In here we got a a small to well, moderate would be there. So we still have somewhat of a small air leak going on in here. All right, let's review some nursing interventions. So interventions that we can do in order to help gas exchange, we can, after we assess that, we again assess the respiratory status and so on. So we want to decrease any kind of hypoxia and everything else. So we want to position the patient with the head of the bed up. A high Fowler's is best positioning for that. We want to encourage that deep breathing to help expand that lung. We want to administer oxygen, supplemental oxygen as needed. And we want to monitor again blood gases and chest x-rays and encourage ambulation. We do not want the patients laying in the bed if they're on a ventilator. I understand that. And we're going to go ahead and we're going to continue to put the head of the bed up and everything, help lower the diaphragm, help expand that lung out. Okay, and we're going to continue to turn them from side to side and rotate them. If they're able to get up to a chair or sit at the bedside, get them up to the chair. Okay, you can get them into the, if you can ambulate them, that's even better. We have patients that are post open heart, post CABG and valve replacements that we walk 3 to 4 times a day. But it's important for the lung re-expansion for ambulation and movement. Laying in bed is not beneficial. Interventions to help prevent infection. This is really pretty much the same as any invasive line anywhere. If you got a central line, you want to maintain the sterility. You want to maintain the sterility. It's an invasive line. It's an open port that's just waiting for something to get in there and just take hold and cause problems. Okay, so think about it as same as using a central line or anything along that. Same thing, right? If we see any kind of drainage or running of fevers, we want to make sure that we're either swabbing around that insertion site to get cultures of any drainage that looks like the possible infections. We want to make sure we're drawing blood cultures and everything else. If we're seeing any of that signs of infections, we definitely got to make sure you're notifying the physician. And then, of course, we want to practice good hand washing before and after any kind of interventions and using our gloves. When we do chest tube dressing changes, it is sterile. It's not just a regular pair of gloves. It's just like you would use on any other central line or any other invasive line. And then, of course, you want to administer any antibiotics as prescribed. Pain. Interventions we can do for pain is assessing and medicating medicating them for pain. If their pain's not being managed or everything else, make sure we're notifying the physician. Sometimes narcotics, morphine, Dilaudid, Norco, are not always the best options for the patient. Sometimes we can actually use something, Toradol, non-steroid anti-inflammatory, an NSAID type thing. Sometimes patients do better with the Toradol. It's an anti-inflammatory, and they do better with that. We want to make sure that we're teaching and showing the patients how to splint. And then, very important, we want to allow them periods of rest. We don't want to overexert them. They got to have periods of rest, and that's going to help. It's going to help with pain management. And then repositioning the patient. When repositioning the patient, we want to make sure that that chest tube is secured, no kinks or anything, and we want to position them for comfort. We also want to assess their psychological, how they're doing psychologically with all the pain and stuff as well. So these are just a few interventions to kind of think about when we're doing interventions. All right, so key points to remember: double check your initial assessment before and after leaving your patient. Check all your tubes, connectors, that the drainage unit is balanced and stable. We want to watch for any type of air leaks in the drainage system, as indicated by that constant bubbling in the water-sealed chamber. I'm going to talk to the patients and make sure that they are reporting any kind of difficulty with breathing to us immediately, right? We do not want them to wait. This can indicate a problem with the chest tube, change in their condition, and we need to know immediately. And then we want to make sure that we're documenting. We need to document it, all of our output on that INO. This says every 8 hours. We're probably on an 8-hour thing. In ICU, we're going to be documenting that every hour. And then out on a telemetry or med surg floor, you're probably going to be documenting it every 12 hours. But I would certainly get into the habit of doing it at a minimum of every 4. I think that would just be a little best practice. That means you're looking at it a little more often, and then you're going to be able to check any complications or excessive drainage earlier. And then we're going to make sure that we're checking those orders and ensuring that we have follow-up chest x-rays and everything as ordered by the physician. All right, additional resources that I told you about. You should be able to click on these sites and get some more information. And then here are some more references that I used. That's it. Sorry I had a little mess up in there and had a little brain fart. I think I needed to take a break. I hope this was very helpful for you, and thank you for listening.